And I'd like to welcome everyone to tonight's webinar titled Emerging Therapies, What the Future Has to Offer. My name is Ann Lee, and I am the Senior Specialist of Programs and Online Education for CANDO Multiple Sclerosis, and I will be with you this evening to moderate tonight's webinar. If you're not already familiar with who we are and what we do, CANDO MS is a provider of lifestyle empowerment programs for people who live with MS and for their support partners. We empower people to actively co-manage their disease and move beyond their MS by adopting active and healthy lifestyle behaviors. And we do this by providing programs for everyone. And you can learn more about these programs by going to our website at www.mscando.org. You can register for upcoming webinars. You can also view archived webinars where all of our previously recorded webinars are archived and held on our website. You can also register or learn more about our in-person programs. We have our flagship 4-day CANDO program. We also have our 1-day Jumpstart programs and our 2.5-day Take Charge programs. You can find out where these programs will be in 2014 by visiting our website. And you can also connect with us on social media. You can find us on Facebook, like us, and you'll be able to get all types of up-to-date information regarding any upcoming events and programs. You can connect with us on Twitter and receive up-to-date tweets about recent happenings with CANDO MS. And you can also find us on YouTube, where many of our webinars are housed and held, and you can check us out there as well. And we are very excited for this evening's webinar. Emerging Therapies is one of our most popular topics. And CANDO MS tries to provide as much comprehensive and accurate information possible regarding all of the research and therapies that are currently available to the MS community. But please be aware that we do not recommend or favor any one therapy over the other. So if you're interested in any of the therapies that are discussed in tonight's webinar, please be sure to talk to your doctor or neurologist about them. So now I'd like to introduce our presenter for this evening's webinar. Dr. John Schafer graduated from the University of Chicago Medical School in 1971, and he completed his neurology residency at the University of California in San Francisco. He has practiced neurology in Sacramento since 1978, and he has an interest in multiple sclerosis dating to that time. He is an MS certified neurologist and practices with Mercy Medical Group in Sacramento, and is the director of Mercy MS Center and Mercy Achievement Center, and is on the faculty of University of California Davis Medical Center. Dr. Schafer is dedicated to improving lives of all with MS through the entire spectrum of the disorder, including those with first attack and those with more severe impairment. So I'm very excited to introduce Dr. John Schafer.
Thank you, Ann. We're going to talk tonight about, the title is Emerging Therapies, but I think that what's really important is to understand what we know about MS and where we are with our therapies and where we want to be. And another thing that I want to include in this program tonight is some idea of what research in MS means. I think people have this vague concept of research of people with test tubes or with rats in the laboratory, but what is how do we really share research findings and how is research conducted? So before we talk about MS, let's talk about what we know about it. Research is a very powerful engine that's got us to where we are. And some very exciting things. So multiple sclerosis, and some of this may be well known to many of you, but just to kind of review it, multiple sclerosis is almost 500,000 people in the United States have MS. Women are much more likely than men to have MS. MS is an unusual for a neurologic disorder because it starts in young adults. The course is remarkably variable. There are people that go through life with a few annoying symptoms, and there are other people who are profoundly disabled by it. And the course of it is very difficult to predict, particularly at the time of onset. So when a person walks into my office with the attack of optic neuritis or myelitis or numbness or double vision. We're not very good at anticipating what that person is going to be like in 5 years or in 10 years. This is a diagram that you may have seen before. The round cylinder in the middle that's labeled axon is the nerve cell, and that jelly roll material around the outside of it is called myelin. That's the insulating material on the nerve. And here's another picture of it where you can see the axon itself in the middle and the jelly roll fabric stuff around the outside. And the importance of that fabric on the outside is that it helps the nerve signal to conduct. The top of the slide here shows this nice little arrangement of these little yellow segments there, and the electrical signal in the nerve jumps from one little space between those yellow segments to another, and that's how the signal gets from one end to the other. Those yellow segments are myelin. And what happens in MS is seen in the second figure down, and where the myelin is lost in that segment and the signal can't get through as easily. And then what eventually happens on the bottom is that the signal can't get through at all, and the nerve doesn't conduct anymore. We know that the cause of MS is attacks on this myelin by the insulating or by the immune system. And here's a really, really simplified diagram of what the immune system is all about. On the left-hand side of the screen, you'll see at the top there T cell. And the T cell is a lymphocyte. This is a kind of a cell that circulates in our bloodstream, and it's sort of the police department of the body. That it looks for stuff that doesn't belong there. It looks for things that are going to be harmful to the body, like bacteria or cancer cells or debris of cells that are dying. And in order to identify these things, the T cell gets activated. It's kind of like the police dog. If you want the police dog to go after a criminal, you pull out a piece of clothing or something that belonged to that criminal, and the police dog smells it and it becomes familiar with the odor, and now that police dog is sensitized to go and look for that criminal. And the same thing with these lymphocytes, that the T cell then becomes an activated T cell. Those orange line up from the top to the bottom of the screen with the little dots in it, that's the blood-brain barrier, or the lining of the artery, and the T cell that's activated gets through that blood-brain barrier to the inside of the brain, and that's where it goes and looks for things that don't belong there, things to which it's sensitized. And for some reason, these T cells think that myelin doesn't belong there. And so through all kinds of weapons, they cause harm to the myelin. So what we know is that it's immune-mediated damage to the myelin. That is, the immune system is causing this damage. One of the new discoveries in recent years has been that the axons themselves, the nerve cells, are being damaged even from the very beginning. It used to be thought that that was a later stage of MS, but we now realize that that's happening even from day one. And as you know, MS can affect particular parts of the brain or spinal cord or many areas. We diagnose MS with an MRI scan, and here are some MRI scans of the brain. These white areas are MS scars. What's the cause of multiple sclerosis? This is another big area of research, is to figure out, why do people get multiple sclerosis in the first place? There can be genetic factors. There's no question about that there are some genes that predispose people to having multiple sclerosis. It's not a hereditary disorder in the sense that if you pass this gene to the child or to your child that that child will have multiple sclerosis, but it's more that that people who get MS are people who have these particular genes. Many, many, many people have these same genes who don't have MS. Epstein-Barr virus infection. Epstein-Barr virus, that's mononucleosis. Very common. Over half the people in the world have been exposed to Epstein-Barr virus, many of them without ever having symptoms of it. But that's a necessary step for someone to get multiple sclerosis. If you've never been exposed to it, or if you don't have antibodies, you won't have multiple sclerosis. So the thought is that having the Epstein-Barr virus in some way primes the immune system in people with these genetic predisposition to get MS. Geography is another big one. We'll talk about that. Vitamin D deficiency. People who develop MS for the first time are much more likely to be low in vitamin D. And again, research in the last few years has shown that vitamin D is effective in fighting inflammation. And so that may be why low levels of vitamin D make a person more subject to MS. Smoking is another factor that causes MS. What about this gene thing? The little red block in the foreground here shows that of people walking down the street, there's about a 0.1% or about 1 in 1,000 chances that a person is going to get multiple sclerosis. The next block up, that purple one, an adopted or non-blood relative has that same chance of about 1 in 1,000. If you have somebody in your family, a mother, a father, a brother, a sister who has MS, the chance goes up, but it's still very small. We're now talking about 3 or 4% chance that a person can get MS. So it's a lot bigger than if you don't have anybody in the family, but it's still very small chance. Twins, it's about the same. Identical twins, look at that green block. Identical twins have the same genes. And if you have an identical twin who develops multiple sclerosis, there's about a 30% chance that the other twin will develop multiple sclerosis. So very clearly, genes have a lot to do with this. And then we talked about the geography of it. So in this picture, the brown areas are areas where there's not very much multiple sclerosis. The red areas are areas where there's a lot of multiple sclerosis. Some of those purple areas up in the upper right in Russia, we don't know. People don't keep very good records. But the point of this is that the closer you get to the equator, the less likely a person is to have multiple sclerosis. Actually, this applies to where you grow up. Where you spend the first 15 years of your life, so that if you're in the northern half of the United States or in Canada, the chances are much, much greater that a person will develop MS as compared to someone who lives in Central America, for example. We think now that the reason for that is sunlight. Sunlight is where you get vitamin D. And so when people are out in the sunlight all year round, they're less likely to get multiple sclerosis, whereas if you live in Minnesota or in Canada where you're inside much of the year or covered up much of the time, the vitamin D levels may be less, and that may explain why there's more MS. This is a very important slide, and let me explain it. There's a line that goes through the middle and rises up on the side that has those little steps in it. And what that is a plot of the attacks of multiple sclerosis. So I'm seeing here whether I can so here we are going along, and we're normal, and then there's an attack of optic neuritis or whatever, and then it clears up and the person's back to normal, and then days, months, even years later, another attack of something else, and then another attack, and this is relapsing multiple sclerosis, relapsing remitting. And as you can see, this bottom line here gets a little bit higher, meaning that recovery isn't so complete after a few attacks. Many people with MS, though not all, reach a point where there's not so many attacks, or even none at all, but there's this kind of progressive worsening of MS. Usually it's in terms of walking, and this is called secondary progressive MS. And the arrows here that we see are new spots that show up on the brain scan. And the point of this is that you can see that there's new spots showing up on the brain scan even when there's no activity going on, no symptoms. So people can have more attacks and not know that they're having more attacks, and that's why the MRI scan can be very important to us in some situations. And then the other lines here we'll kind of pass over quickly in the interest of time. This dotted line is a line of the overall burden of these spots. So most multiple sclerosis is relapsing remitting, at least at onset. And then some people become secondary progressive. There are some in that blue piece of the pie that are progressive from the very beginning without any attacks or remissions. Let's talk about MS research. What is MS research? So the goals of research, what we want to do is we want to stop attacks of multiple sclerosis. We want to stop progression. And remember in that slide that we looked at, there's a difference. That in the early part you see attacks, and then people get over the attacks, and then another attack comes along. And while it's not nice to have attacks, still people recover from them largely. But the bad part of MS is this progressive part, and that's the part that we saw where it was just kind of slowly going uphill there with worsening of walking or cognitive functions or whatever. And we think that's a different process, and that's what we want to stop. It would be great to be able to reverse the damage caused by MS for somebody that's not walking, to find a drug that'll make them walk again, or losing coordination that will bring back the coordination or the vision. And then, in the end, wouldn't it be great if we could prevent MS from occurring in the first place? Kind of like the Sabin and the Salk vaccines for polio. Polio was a big scourge, but the vaccination was found, and we pretty much don't have that anymore. So to do this, to reach these goals, we first need to find out what exactly it is that causes MS, how the damage to MS takes place, how the body can repair the damage. You know, I think an analogy that I thought of this is if your town was overrun with rats, let's say, and they were everywhere, and this was way out of the proportion of what you could do with rat traps and rat poisons, and you had to figure out how to get rid of these rats, and you were put in charge of this, what would you do? You would want to find out everything you could about rats. You know, where they live, where they don't live, how they mate, you know, how many babies they have in the litter, how high can they climb, how low can they crawl, how big a hole can they go through, you know, what do they eat, what do they not eat. All of these things that would then tell you about what you can do to prevent them from reproducing or prevent them from spreading. And it's the same thing when we're talking about a disease like multiple sclerosis. If we could figure out how those white cells, those T lymphocytes get get sensitized and how they get into the blood-brain barrier and where they're made. Those are the things that will be the clues to bringing us new treatments. There are a lot of areas of research in MS. New treatments, genetics, what's the mechanism of action of all of these drugs, the immune system. The immune system is enormously complex. Viruses, remyelination, how do we put the myelin back on, social and personal impacts, rehabilitation research, nursing research, economic research. There's all kinds of research that's involved in multiple sclerosis. Who performs research? Well, most of the drug research these days is done by pharmaceutical and biotech companies. Used to be done by universities, but less gets done in universities these days. Maybe because the universities don't have that money to invest in research that sometimes are risky. You may put a lot of money into developing a product and find out it doesn't work. National Institute of Health is the biggest provider of funds for research, the nonprofit research institutions. Other non-affiliated groups, the National Multiple Sclerosis Society is a big funder of research for all of these aspects of multiple sclerosis. And I want to tell you, so where are these things reported? There's a couple of big meetings that take place each year where multiple research or sclerosis research is shared. The ECTRIMS, that's the European Consortium of Treatment and Research in Multiple Sclerosis. This is the biggest gathering of MS specialists in the whole world, and there's 7,000, 8,000, 9,000 researchers or clinicians that gather together every year in various parts of Europe. The most recent one was in Copenhagen in early October. I had the pleasure of attending that. The American Academy of Neurology meets every year and has a lot of reports on research, updates, and the Consortium of Multiple Sclerosis Centers, American Neurologic Association, and there are some others as well. Just to show you a couple pictures, I think it helps to see. So here's the ECTRIMS meeting, and it shows the large number of people listening to a speaker who's talking about a particularly important part of MS research. You may have heard of posters. So these are posters that particular research department, say UC San Francisco or Dartmouth or Stanford, is working on a particular project, and they report it in the form of a poster, and these posters get spread around, and there's like hundreds of these. And so you can see that the people who are visiting walk around among these and look at the things that are interesting to them. The authors of each of these posters are standing by the posters so that you can ask them questions about it. What kind of things do they look at? So here's one, exercise therapy for those who are moderately affected with multiple sclerosis. So some of them are real practical. Some of them are less practical. I had some other pictures in there of things that how oligodendrocytes metabolize some protein or something, things that even for a professional you may not understand or may be difficult to understand, but all of these little pieces of the story. So different areas of research, as we said, epidemiology, who gets MS, how does the damage to the myelin occur, how can we get better at diagnosing and predicting the course and discovering new treatments. One is to identify those who are at risk, and this can be done how MS responds to treatment, complex interaction of genetic and environmental interactions, how genes, that many genes, but not just one gene, contribute to this. How does the MRI help us? MRIs help to diagnose MS and to differentiate it from other disorders. It doesn't tell us a lot about disability. People can have lots of spots on an MRI scan and be pretty normal, and people who are quite impaired may only have a few spots. That's one of the mysteries. So it doesn't tell us a lot about how people are going to do in the future just by looking at a single MRI scan. Some of the newer MRI techniques, the diffusion tensor imaging, this shows all of the individual nerve pathways in the brain that, and we can see how they're connected and when they become disconnected. MS may be different diseases. This finding might explain why differences in severity and patterns of MS and different responses to treatment. And going back to this slide, the early course here is the relapsing remitting course, and what's going on in the secondary progressive. We think more and more now that these are different processes that are going on. T cells or B cells. The picture I showed you back there is the T cells, and the T cells are part of the immune system, and that's always been considered to be the main culprit in causing damage to the myelin. But just in the last 5 years or so, it's been discovered that B cells, which are a different kind of lymphocyte, that nobody ever thought these had anything to do with MS, but it turns out that they're vitally important because the T cells need to have the B cells there. Some of the newest treatments, and I'll show you a list in a few minutes here, are treatments that work on the B cells, not the T cells. So let's talk about treatments. There are the treatments that have been around for a long time. Corticosteroids, that's prednisone or methylprednisolone or solumedrol, steroids. These have been the longest of any currently available therapy. They're anti-inflammatory. They benefit exacerbations in relapsing remitting MS. They have less benefit to fixed symptoms. Once a problem has been there for a while, it's less likely to respond to that treatment. There's no benefit to the long term. In other words, whether you take steroids or not for an attack doesn't seem to have any bearing on what things are going to be like in a year from now or 5 years from now or 10 years from now. Steroids can be given intravenously or by shots into the muscle or in the form of pills. Now, we didn't have any treatment for the long course of multiple sclerosis until 1993 when beta seron was invented, or was released on the market. So up until that time, the only thing that we could really do was to treat the symptoms. We couldn't treat the disease. There was nothing we could do to reduce the chances that someone was going to have an attack or the chance that they were going to get worse. In 1993, beta seron was released on the market. Beta seron is a beta interferon, and so another one then that followed that is Avonex, and then Rebif and Extavia, all of which are beta interferons. Copaxone came around in about 1997. It's a very different medication, but the outcome is the same as with the interferons. All of these are injections that people give to themselves. We know that they reduce the risk of attacks and they reduce the risk of new spots showing up on the brain scan. We also know that these medications have a very low risk of any serious effects either in the short term or the long term. They delay progression, and the effect of conversion to secondary progressive is unknown. What I said a minute ago is that some people with relapsing remitting MS develop secondary progressive MS after a period of time. Do these medicines reduce the risk of that or delay it or modify it in any way? We're not sure yet, and that's because even after 20 years, that hasn't been long enough necessarily to be able to tell. The next wave of medication was natalizumab or Tysabri, and this, is, some of you know, is an intravenous infusion which is given once a month. Again, it reduces the chances of new attacks or of new spots showing up on the brain scan, and like the others we showed, it delays progression. It may be more effective in preventing the attacks than the other drugs we just mentioned, and in some ways it's easier to give because it's intravenous once a month instead of a shot daily or 3 times a week or once a week, but it has some risk to it. There are the other medications, as we know, they don't affect the immune system in a way that makes a person get more infections of any kind or more tumors, whereas with Tysabri, there is a risk that it may activate viruses that live in the brain that are otherwise kept under control by the immune system. And the long-term adverse effects we're still not entirely sure of. Then there are oral medications. So shots are good, but pills have been the kind of the latest entry, and it's nice to have an option for pills. Gilenya and Aubagio are pills that have similar effect to those that are injectable. Again, all of these medications have the same effect, that they reduce the chances of having new attacks. None of the medicines to date has been shown to reverse damage that's already been done, and as far as what the effect of these are on preventing people from becoming secondary progressive, we still don't know entirely well. Then the most recent one, BG12, Tecfidera, another pill that it's a pill that you take twice a day. So Aubagio and Tecfidera are the latest ones. With the Gilenya, there is some concern about some side effects. They're very rare, but potentially serious. With teriflunomide, Aubagio, and Tecfidera, while you're always holding your breath when there's a new medicine that comes out, it doesn't look like there's real serious problems with these, more some annoying side effects. But I think that with any new medication, we always hold our breath because there are plenty of examples of things that have been on the market for a number of years before it's recognized that they cause problems that they cause. I'm just going to run through quickly. Laquinimod is another medication that again reduces. This is not on the market yet. It's a pill form. It doesn't have quite as good an effect in preventing attacks, but interestingly, it seems to do more for preventing progression of disease. Here's a list of the newest medications that are in trial. Alemtuzumab. Actually, alemtuzumab was presented to the FDA last week, and the FDA declined to release it because they wanted more information on what its how effective it was. Ocrelizumab and rituximab are medications. These are examples of medicines that work on the B cells. This is what I was saying before. We've always kind of thought of the T cells as the main culprits, but these medicines attack or suppress the B cells, and and look like they're very effective in stopping MS activity. The problem with all of these is the stronger they get, the more you worry about adverse effects. And so that's kind of where we stand with these now, is we're waiting to see how safe these are going to be. Are these medicines things that we're going to use for everybody that's got MS, or just for those that have got really bad MS? We always ask about stem cell therapy. Stem cell therapy is an exciting area. There's a number of different ways in which stem cells are used in multiple sclerosis. There are trials that have been going on actually for several years in which stem cells are used not to replace the myelin or the damaged brain cells, but rather to replace the immune system. You might think of in MS as the immune system is being corrupt. It has these, it's raising these cells that go out and attack the myelin. So one type of stem cell therapy is to completely wipe out the immune system, which is done with radiation to the bones and to the lymph glands, and then chemotherapy to knock off whatever cells might still be around there. And then you give stem cells that from the immune system that repopulate or make a new immune system, and the hope is that that new immune system isn't going to be as harmful to the myelin. But in the future, stem cells may be used to replace damaged myelin, or to turn the switches on cells that make myelin to make them make more myelin. And so these cells are going to be important. I'm trying to advance these here. Just a couple of things to end up with here. Who should take these drugs? So all of these drugs we've been talking about are called immune modulator drugs. They modulate how the immune system works. And those with relapsing remitting MS. And what we've learned is that even if the symptoms are mild or a small number of attacks, these medicines have their greatest effect when they're used before damage has occurred. We know that the question has always been, what do we do with the first attack? Somebody comes in with an attack of optic neuritis. So these are called clinically isolated syndromes, or CIS. So how do you know whether this person is going to have any more troubles or not at all in their lifetime? And we can, here's an area where the MRI scan can be predictive and show us if there's a lot of plaques there. It means that there's a much greater likelihood that someone is going to have trouble. And so we know that it's best to start medications even after the first attack in people like that. So people with relapsing remitting attack are the people that that could probably benefit from these. We know that they delay and maybe, this is hopeful thinking, even prevent this progressive phase. No treatment has been shown to help once the progressive phase is underway, and so that's why long-term studies, that is 15 to 20 years or more, with beta-seron and Copaxone and Rebif showed that even years later, the people who started the treatment earlier were the better off. So again, just a reminder, this important slide that shows how this conversion from the relapsing remitting MS to the secondary progressive MS, the hope is that by treating this stuff down here, that not only do you decrease the chances for these, but that you decrease the chance for this change here. What about progressive MS? We don't have any good treatments for it. There's a great deal of research that's going on. Question always comes up, if I have progressive MS, should I be on any of these medicines? Will they help me? The thing is, we don't know when that dividing line between relapsing, remitting, and secondary progressive occurs. Patients often ask me, how do I know if I have secondary progressive? And the answer is, well, compare your status to a year ago. If you're having more trouble walking now than you did a year ago, and if it's a significant difference, then you probably have secondary progressive. But progression doesn't occur overnight, and there may still be a mixture so that therapies can be helpful. Let me just say a few words before we close up here about alternative therapies. So there's a wide variety of treatments that have been tried for MS and have been reported by some individuals to be helpful. But what's lacking in these are clinical trials so that you can find people who say, I took such and such a medicine and it was wonderful, it made me walk again, but what you don't know is how many people took it and didn't get that effect, or how many people took it and got worse or had side effects from it. And so with clinical trials, there's complete revealing or transparency of all of the possibilities of what happened. We have symptomatic therapy, things for pain, things for bladder function, medicines for fatigue. So just in summary, what we know, although no cure exists, the disease-modifying therapies are available which can have a dramatic effect on the early course, which may delay or prevent the progressive behavior in the later courses. Choosing therapy that's appropriate for the long term is important. Ongoing clinical studies are advancing our ability to treat MS effectively. Management, I always want to point out, includes expert rehabilitation. That's physical, occupational, speech therapy. It's not all pills. There's other ways of coping with MS, and that's really what Can Do is all about, is what are all of those other things that are really crucial to managing one's life when you have MS. What we need a treatment to reverse or stop the progression of MS, to fix the damaged myelin. And research is looking at this. Unfortunately, I don't have anything yet that I can write you a prescription and send you down to the pharmacy to pick up, but that'll happen. Better treatment for the cognitive problems and for the fatigue. These are particularly hard to treat with medicines. What we really need are better ways of predicting who's going to get MS in the first place and what will be the course of those after the initial symptoms. So this is very crucial, especially as we have an array of medications or treatments, some of which may be more harmful than others, or more risky, I should say. We're going to need to know how to decide. So at this point, I think we have time still for questions.
Yeah, absolutely.
Let's open that up.
Sure. Thank you, John, for Dr. Schafer for that webinar and all the important information that you provided. We did receive several questions by chat. And the first question that we've received is this webinar participant, she's had MS for 4 years, and she's had memory loss this entire time, and she's wondering if she'll ever regain her memory.
So memory issues are a big problem with MS because we don't have any great treatment for that. You can read on the internet actually a lot of suggestions about how to deal with memory. I mean, even things like exercise or some kinds of food supplements and things may benefit memory. I think an important thing is to look for cognitive programs. Again, can address this. The National Multiple Sclerosis Society has what's called CogniFitness, which is a program that runs in most communities once or more times a year, and these are strategies for dealing with the cognitive problems from MS. But again, early treatment is something that we're hoping will prevent this from happening.
Okay, excellent. We have another question here. This person has been on injectables for 15 years, and they are undecided about switching to a pill since she's been okay with her current meds. She's afraid to rock the boat, or should she just not worry about it and just switch to the pill?
Well, I wish I could give you a real good answer to that, but that's the question that I ask, with pretty much every patient who I see. There's pros and cons. What we know about the injectable medicines, pretty much all of them, is that they work. It's clear that they work, and even 15, 21 years on the market, they still work. And we also know that they're really very safe, with the medications that are the platform medicines, those that you inject under the skin or inject into the muscles. There hasn't been any evidence, even after 15 or 20 years, that it makes people have more infections or more cancers, or that it messes up the immune system in any way that is going to cause harm. The pills that are available now, particularly the two most recent ones, the Aubagio and the Tecfidera, don't seem to have any big worries about them. They seem in the short-term trials like they work. As I say, we always kind of hold our breath about, are they going to still be as good after you've been taking them for 5 to 10 years, and are they still going to be as safe after they've been on the market for 5 or 10 years? We don't have any reason to think that they're not going to be, but we don't know. So I guess it depends on how unhappy one is with the injections. If you're doing okay with it, if it's working, it works. There's no reason that one would have to switch. The pills aren't better, let me put it that way. So it really depends on how much difficulty a person has tolerating the injections. I hope that that's helpful.
Great, thanks. So we had a few questions about PML, and this person's question is, can you tell us or tell me more about PML and what it can mean for a person? This person's father was taking, and I'm sorry if I pronounce this incorrectly, but Tysabri, Tysabri.
That's correct.
And,
very good.
Thank you. And is now PML positive.
So PML is caused by a virus that attacks the brain. The interesting thing is that many of us have this virus. It's actually called the JC virus. And many of us have the virus in our bodies, but the immune system keeps it under control. Now, Tysabri blocks the pathway by which the immune system keeps those viruses under control. And so the result is that the virus can, in some people, pop out and become an infection. And it's a viral infection of the brain that can cause severe damage. In fact, it can be fatal, and even when it's not fatal, it can be a lot worse than the MS was in the first place. So this is a really scary part of it. Now, it turns out that we can predict what a person's risk is for developing the PML by looking for antibodies in their bloodstream. that if people don't have antibodies, it tells that they probably don't have the virus in their body, and the chances that they're going to get PML from Tysabri is very, 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 very remote, small enough that it wouldn't be a consideration. On the other hand, if they've got the antibody, in some, depending on how much antibody they've got in things, it can be as much as, 1 in 300 or 1 in 500 chances of getting PML. Now, what does that number mean? 1 in 200, 1 in 300? Is that a lot? Well, it's enough to make a doctor worry, where I'm going to start a lot of people on this, and it makes patients worry too. So, and we do know that this risk comes on after people have taken it for a couple of years. So not at the beginning, but after a few years. But it is certainly dulls one's enthusiasm for taking it if one does have the virus. I think it comes down to how bad was the MS in the first place, and what was the reason that Tysabri was started. And now I think with some of the other newer medications, we may have some more options. Again, I hope that gives some guidance to the person who posed this question. It is something that we're concerned about.
Excellent. So we had a couple questions regarding Copaxone. One question is there a pill form of Copaxone? If not, is there one that might be coming out? And also, don't pills such as Gilenya have a higher success in preventing relapses, such as 50%, versus injections, which are at 30%, like Copaxone? And are those accurate figures?
Okay, so 2 questions. Is there a pill form of Copaxone? No, there's not. It is of interest that Copaxone, that Teva, the maker of it, is submitting to the FDA a request to release a 3 times a week version, so an injection that rather than every day, it's given 3 times a week. It's twice the strength. And so it'll be interesting to see whether the FDA passes on that. It looks like it has about the same benefit. The question about effectiveness of medicines is a sticky one, because when you talk about 30% effect versus a 45% benefit, what they're talking about is the percentage of people in the placebo group that had attacks in any of these trials versus the percentage of people who were taking the medication. And so when you do a clinical trial, half the people get the real stuff, half the people get the sugar shot, and then you see at the end, or the sugar pill, and then you see at the end, which group had fewer attacks, and you can express it in terms of a percent, that the people who took the medicine had a 30% less chance of having an attack than the people who weren't. The problem with those percents is that in every trial, the placebo group does differently. And there are some trials where the drug has failed to become to be shown to be beneficial because the placebo group did really well. So if by chance your placebo group, there aren't very many attacks, you won't be able to show that the medicine was better than the placebo because the placebo did really well. And that is really just a matter of statistics. I'm not arguing that placebos are good for MS necessarily. And so that's why it's very difficult to compare. Drug companies certainly like to do it, to say, well, gee, we were 46%, and that one over there was only 42%, but it really doesn't. It doesn't. You can kind of divide things up into general categories or general ranges. But I think the answer to the question is that I wouldn't conclude that pills are more effective than injectables necessarily.
Okay. So this is a specific question that we received. This person was on Gilenya and went off of it because of her side effects. She is secondary progressive relapsing remitting, but she decided not to go on anything else for now. Do you think that this was a wise decision or just a matter of opinion?
I think that if there's relapsing remitting activity, that one would benefit from having a treatment. Now, how do you know that? I mean, it can be, are you having attacks of new things? It can be, are there new spots showing up on the brain scan? Also related to when you say you're secondary progressive, how long has it been secondary progressive? If it's been secondary progressive for 15 years, then there's, in my mind, less chance that any of the medicines are going to be helpful. But if it's been progressive for a few years, then very definitely medications may be a benefit. So I think these are all factors which would go into the decision of should you switch to a different medication. And I think things that your doctor can probably best answer for you. And if you don't think your doctor is giving you a good answer, get another opinion.
Right. Excellent. Okay, so just one final question that we'll be able to take, and that is how close are we, or are there movements or advancements to myelin replacing treatment?
You know, there's tremendous advances in myelin treatment. I was just this past weekend at the National MS Society annual leadership meeting, and there were, although it's not a research meeting, there were a lot of research exhibits by young scientists who are receiving money and support from the MS Society. And I was really very struck by how many projects are aimed at this. How do you make myelin grow? How do you figure out how oligodendrocytes make myelin? How do you juice them up? So there's a great deal. There's actually is a very, very small clinical trial that's going on right now in humans. This is a phase 1 trial where, as they say, a small number of people will get it to make sure that it's okay to give to human beings, that will see whether does this medicine make myelin regrow. And then the question is, if you make the myelin regrow, are the nerve cells still going to work? If the myelin's been damaged for too long, they might not. Complicated story, but the answer is there's a great deal of research in that area.
Excellent. And so there were several other questions that came in, and I apologize we did not get to them. But we will, just for the sake of time, we will have to close the Q&A portion of the webinar. I do want to talk about some of the resources that Can Do MS has on our website, and one of them is our Ask the Can Do team. So for these questions that you folks had that you were not able to get answered, you can go to our website and search for our Ask the Can Do team page and submit your question on there, and we'll be able to forward them to the appropriate programs consultants or staff members to answer those questions for you. You can also search for our e-news, which is our electronic monthly news article that we email to all of our program participants, and it includes information about any future upcoming events and programs. And we also have our Can Do library, and our Can Do library is written by our MS experts and program consultants on various topics in health and wellness and MS. So please be sure to check out all of those free resources. So before we close off the webinar, I do want to mention that our Vertical Express events are coming up in 2014. If you aren't aware of what this event is, it is our flagship fundraising event and our oldest one. And its first event was in 1985, which was started by our founder, Jimmy Huga. And this event is a series of on-snow fundraising activities for skiers, snowboarders, and telemarkers of all ages and abilities. And the fundraisers are held at 4 different mountains in 2014 in Vail, Crystal Mountain, Washington, Squaw Valley, California, and Schweitzer. So please feel free to check out our website and go to mscando.org/vertical express to find out all the info. And our next webinar is on December 10th, same time, and the topic is Coping and Adaptation, Strategies for Individuals and Families Living with MS. And they will be presented, the program will be presented by program consultants Rosalind Kalb, who is a psychologist, and Mandy Rourke, who is our physical therapist. So please join us live from the convenience of your home or office. And for those of you who are participating live tonight, once this presentation is over, you'll see a survey pop up on your computer screen. So please take a moment and complete that survey and share with us your input. Your feedback helps us continue to improve our webinars. And you'll also receive a copy of tonight's webinar slides in a PDF format, as well as you'll be able to access the recording of the webinar as well on our website. So appreciate all of y'all's time, and thank you so much. And Dr. Schafer, again, thank you for all of your expertise and your time in investing in this webinar tonight, and hope everyone has a great night.
Thank you. My pleasure.